Hello there, abnormal psychology students. I'm going to have a little lecture on neurodevelopmental disorders. Kick back in my chair. My apologies for having to miss these days, but I'm listening to my surgeon, which is a good thing to do, I guess. So there's several different kinds. You can read them there. Mood, anxiety, disruptive impulsive control, conduct, neurodevelopmental disorders, elimination disorders, child abuse I put in there, and then neurobehavioral disorder associated with prenatal alcohol exposure, formerly known as fetal alcohol syndrome. So here's some mood and anxiety disorders in children: separation anxiety, other anxiety, disruptive mood dysregulation disorder is kind of a new one. It's new to the DSM-5. What was found, this is again sort of an interesting history, that a lot of people were diagnosing bipolar disorder, but there was just didn't make sense. When we looked at it, it was more this disruptive mood dysregulation disorder, and we'll get to that in just a few moments here. So here's separation anxiety. Here's a key one: developmentally inappropriate and excessive fear. This is where it gets to be clinical judgment time. What is developmentally inappropriate and what is excessive fear? Again, that's clinical judgment time. It's not science, it's clinical. So you have to make that call. And with that, you also look for school refusal and phobia. That's part of it as well. And it's for whom the individual is attached. Okay, so it's like mother, father, this is an attached figure. So separation anxiety. Kids can have all these other ones too. Okay, they can have GAD, generalized anxiety, obsessive compulsive disorder, depression, bipolar. Separation anxiety is already listed up there. So they can have those as well. Bipolar is less often, but certainly can get depressed kids and manic kids. I might even save this for next week when we talk about stuff. Basically, bottom line is antidepressants can be used in children. They have to be used carefully, and that's where people get careless, in my humble opinion. But if you know what you're doing, you can use these medications really quite well. Here we are, disruptive mood dysregulation disorder. Main thing here is temper outbursts, okay? Severe and recurrent temper outbursts. They get really mad, really fast, grossly out of proportion, intensity or duration. So they're just really out of control anger, temper outbursts. And again, inconsistent. These are all those clinical judgment things on a developmental level. 3 or more a week. Persistently irritable in between. So these are just angry little kids. Okay. Usually needs to be made between 6 and 18, but present before age 10. Because if they're adolescent, right? If they're adolescent, they might just be having this because these anger outbursts because they're adolescents. So it has to be before 10. Okay, before age 10, but usually between 6 and 18. Developmental level before 6. Okay, before 6 it might be maybe not completely appropriate, but certainly not as inappropriate for children to have temper outbursts. So between 6 and 18, symptoms before age 10. Okay. Oppositional defiant, conduct disorder, impulse control disorder. Hold on here, my doggy needs to come in. Okay, so back to here, my doggy came in. Disruptive impulse control and conduct disorders. Okay, so oppositional defiant, conduct disorder, and impulse control. So not quite in the same order, but there you have it. Oppositional, they're just kind of negative kids. They just argue. So they don't get mad so much as they just argue over everything. Loses temper, but not as much, not as intense as dysregulative mood disorder 1. But they do lose temper. Argue again with everything. Defies, refuses. It's annoying. Very angry and resentful. Vindictive and spiteful. So these are just kind of irritable, arguing kids. Oppositional defiant. Again, a lot of this is clinical call time. I'll keep emphasizing that because you really have to make that call. What is more than normal. That said, sometimes it's really quite obvious. Had a kid once that had a diagnosis of oppositional defiant disorder, and he said, "No, I don't." Get it? Argues. So it's kind of funny, but again, these can be quite difficult kids. Hold on. see, next slide. Some other things they do: argue with parents a lot, don't clean their rooms, don't obey curfews. Usually in preschool, as it comes up early. Rarely it comes later, but usually it starts during preschool years and may proceed to conduct disorder, which we'll get to in a second. Also has increased risk of mood and anxiety disorder. So these all kind of flow together as you'll kind of pick up here. Differential diagnosis, DDX. Get used to that, DDX. Differential diagnoses. Again, disruptive mood dysregulation disorder. In oppositional defiant disorder, the temporary outbursts are less severe. Again, what's the clinical call? It's kind of hard, but you got to make it. You can have attention deficit hyperactivity disorder with oppositional defiant disorder. You can have both. And treatment, counseling. If there's co-occurring disorders, treat those. Management training for parents, school-based programs. So, not really medications. And people use medications, for like 10x and clonidine. They can be useful. They decrease some of the agitation, but for the most part, the treatment is psychotherapeutic. Intermittent explosive disorder, really aggressive and really behavioral. They just, boom, they're out. Verbal aggression behavior. Inability to control aggressive impulses. That's kind of a big point there. It's not just that they're mean, but they have impulses that they can't control. They don't plan things, they just go off, basically. So page 379 talks about it. Mainly young men with low frustration tolerance. And there's things you can do to treat them. These various medications, second generation antipsychotics, of course. And cognitive behavioral therapy. Yeah, that's another big one, CBT. So again, verbal aggression, tempers, tantrums, arguments, destruction of property. Not premeditated. Again, that's another big one. It's not premeditated. They don't think about this. They just up and blow up for no reason. That's the whole definition. And it can't be explained by another mental illness, substance use, psychotic illnesses, etc. So if something else can account for it, you have that instead of intermittent explosive. Conduct disorder. This is the attitude. They don't really care. They don't really care about others. They just violate other people's rights and social norms. They're aggressive, they bully, they fight, they use weapons, cruel to people and animals, like ridiculously cruel. Not just, a lot of children will be cruel to animals sometimes, smash a spider or blow up a slug, something like that. This is they burn cats and stuff. I mean, they're just horrible, these things. Stealing while confronting a victim, rape, and you can tell these children tend to grow up to have antisocial personality disorder. So again, some more different definitions, different characteristics of conduct disorder. Property theft, serious violation of rules. Different types: overtly destructive, overt non-destructive, covert destructive, covert non-destructive. So there's just sort of subcategories of conduct disorder. And a third have ADHD as well. That makes for a much worse prognosis. So conduct disorder with attention deficit hyperactivity disorder makes for a worse prognosis in general for these folks. Childhood onset, adult onset. So later onset, the better prognosis. And if you have some pro-social emotions, you do better. But if you have limited, like no remorse, callous, lack of empathy, unconcerned about performance, they don't care if they get Fs in school, they just don't care. That is really poor prognosis. In fact, some people would argue that this syndrome with these different clusters of symptoms in conduct disorder constitutes a different thing from regular conduct disorder, or not regular so much as ones without those symptoms. And it might just be more, might be a completely different disorder, but that's a matter of debate. We don't know that yet. Here we are. Here's a good prognosis. Earlier onset, poor prognosis, early onset, greater comorbidity, like I just said. And more social norms internalized, that's better prognosis. Able to form relationships, that's also good. Can occur with mood, anxiety, and ADHD, and specific learning disorders, dyslexia, dyscalculia. Those can go along with conduct disorder. And some would argue that the conduct disorder is a coping mechanism for the underlying learning disorders. I'm not sure if I agree with that, but it does make some sense. And here we are. parental problems, highly deviant families, I think is a quote from your text, which I think is kind of a fun thing. um, but lots of stuff. Community violence. If you grow up in a violent community, you tend to be violent. Socioeconomic status, lower socioeconomic status tend to have more. Although you can argue that higher socioeconomic status has these, but they can just kind of get away with it more. That's a question in my view. Trauma, drugs, etc. Some genetics. So those two are tied together. And I always put in choice. Sometimes people can not choose to not do those things if they really were so motivated. And here's some treatments for you. I won't necessarily go into them. Some other just sort of impulse control disorders. There's pyromania, which is a fascination rather with fires, and kleptomania, fascination with stealing things. The main point with both of these is the tension and affective arousal before setting something on fire and stealing something. You have to have that. You have to have this kind of force. I need to do this. I need to steal this or set this on fire. And then afterwards, it's burning. That's great. Watch it burn. Wow, I stole it. This is so cool. Whatever it is, I stole it. That's one of my doggies in the background. There's a disadvantage of dictating at home, is you get to hear my dogs. With pyromania, there's no monetary gain. That's kind of a key thing. Although a lot of folks will try to get into fire and rescue. If they set something on fire in order to get a job, right? And if they set a forest fire in order to get a job, by definition, it's pyromania. Though in my, albeit limited experience, I think there's some overlap. Again, the tension, affective arousal, they just kind of get into it and watch it burn. It's so cool. Just kidding. That's probably going too far. Anyway, next slide, please. How do you treat it? Co-occurring disorders. No real meds, family therapy, other ways to cope. Cognitive behavioral therapy, of course, is there. Kleptomania, interestingly enough, is mostly women. I'm going to see if I can get my doggy to come in. Hold on. Pause this. All right, got that doggy in. So again, interestingly enough, SSRIs and naltrexone, that's an opiate blocker, has been used for kleptomania. So kind of an interesting thing. SSRIs, if you remember, are selective serotonin reuptake inhibitors, SSRI. Pretty chronic. Kleptomania will go on for many years. So it's an obsession. It's an impulse control. So that's why it does that. And cognitive behavioral therapy for that, of course. So no clear role for meds in pyromania. Just nothing's been found to work for that. Here's some PubMed articles on internet addiction. These did not make it into the DSM-5, but wow, the internet gaming disorder, it's a thing, as they say. It's a thing. I would look those up if you want. You might want to. I think there's a question on the test about them. So basically, it talks about how many guys, but I think to some extent gals, will just be on the internet gaming for 24 hours straight. That's all they're doing is just gaming. That's just wow, that's quite impairing. So ADHD, here's a neurodevelopmental disorder. Attention deficit hyperactivity disorder. By the way, there is no ADD. It's all ADHD. People still have ADD. They haven't kept up. It hasn't been AD. There's been no ADD since DSM-3. We're 2 on now. The reason for that is that it was too hard to tell if there's hyperactivity or not, and usually there was at least some hyperactivity. So in order to have more inter-rater reliability, it's all now called ADHD. And it wasn't any difference in the treatment anyway, really. So autism spectrum disorder and intellectual disability. So generally some things to think about. Read this, page 89, it's really good. Who's the patient, right? Is it the parents, and what's the role of the parents, etc.? You need to have the family more involved than you would in general. Where are they developmentally? Okay, longitudinal. Are these quote-unquote symptoms actually just due to their developmental stage? All these questions need to be considered when looking at neurodevelopmental disorders. A lot of non-physician in the care, case managers, teachers, counselors, etc. Usually quite a bit of people besides physicians. and they need a physical exam. Is there some other thing going on medically, thyroid problem, etc., that we've talked about, that or abuse actually, that can be setting off some of these issues. So with ADHD, there's attention, hyperactive, and impulse dysregulation. Okay, even though there's the impulse dysregulation as the main factor, it doesn't make it into the title. I've never known why, actually. I guess just easier to say ADHD. Here's DSM-5 diagnoses. You can look that up. And 108 and 110 also has some definition. So, but attention, hyperactive, and impulse control. Here's some things that I put in. Basically, you can go through these quickly. Dopamine, norepinephrine, and frontal striatal. Again, this is an old slide. So put an H there, put an H there. I should probably get rid of this slide. It's just too old. But it shows the point, right? So smoking during pregnancy. Mothers who smoke increase the risk of their child having ADHD by quite a bit, actually. So do not smoke while you're pregnant. EEG changes, that's what we're showing here. SpongeBob's a little bit tongue-in-cheek. There's a study where kids watch SpongeBob and they're, nuts. But you might notice I did not capitalize those. I did that on purpose. I've only glimpsed that cartoon a few times, and it's really irritating. Is it being diagnosed too much? Yeah, I'll let you argue that one. Genetics, dopamine transport. That's the gene that brings the dopamine back up into. It's the reuptake gene, transporter, reuptakes dopamine. And of course, you see different sizes here. Hypoperfusion. This is all prefrontal cortex. Ganglia is movement. Cerebellum is also movement. So it makes sense that these areas are abnormal when you look for ADHD, because that's where hyperactivity and attentional processes lie in the brain. And lots of things to treat it. EEG biofeedback is kind of interesting. This is an old computer, obviously, but I think the data on that's still pretty good. I've been looking into that just out of curiosity, how good the data is on this, but it looks like it might be pretty good, really. And of course, other stimulants are used: Ritalin and Adderall. Strattera is a norepinephrine reuptake inhibitor. So antidepressants that act on norepinephrine and dopamine, like bupropion, also can be used to treat ADHD. So quite a few options. The first ones are usually Ritalin or Adderall. Or Adderall. They both are noradrenergic agonists. Adderall is amphetamine. It's an amphetamine salt mix. It's not methamphetamine. That makes a big difference. Side effects: appetite suppression, irritability, abdominal pain. Overall, people learn how to manage it, and you can use operant conditioning, rewarding good behavior, not rewarding undesirable behavior. So learning that's a psychological aspect of treating ADHD. It's not just medications, of course. Adults and adolescents seek stimulants. It does help your school achievement. People get buzzed, right? You get a little bit of a buzz off those things, so you have to be careful around that. People want to get prescribed amphetamines, because you can abuse them if you want it. People can abuse lots of things. And in high doses, you get too much dopamine and you get psychotic. Ain't that special? Calculia, for mathematics, dyslexia for reading, specific learning disorders. You really need to look for these more. In my opinion, we might want to look for dyscalculia more in college students, because it seems many college students will say they're, quote, bad at math, unquote. And that's usually what they say, is bad at math. I wonder how many of those have actually dyscalculia. Just curiosity to me. Language disorder, speech disorder. I'm going to skip over these some. You can read about them in the textbook, pages 100 to 101. This basically, people have a hard time with language development, hard time articulating, fluency, stuttering. People who stutter, that's a disorder by definition. And pragmatic communication disorder, they're just sort of socially awkward. Not autism. Otherwise, they can tell faces, etc. But they're just socially awkward. Motor disorders, coordination. They're just physically awkward and clumsy. Getting dressed. Oops, I forgot to close the parentheses. Hey, don't want to do that. Just impairs performance, daily activities. Stereotypical movement disorder, again, you can read that. Tics, motor behaviors that interfere. This is a key thing here. Interfere with social, academic, and other activities. Okay, that's a key qualifier for all these different things. You have to have that impairment, significantly impairing. So that's a key component to all these diagnoses. Tics. This is movement. Tics. Volunteer muscles, striated muscle. And you can also have motor tics. Sometimes they can be offensive. Okay, they can say little swear words when they're going, motor tics. But they also know they're making those. They can also be odd, offensive, all that kind of stuff. Motor tics can be offensive too. I guess that's the point. Flipping someone the bird or something like that. These tics get worse when you're anxious, interestingly enough. Here's some interesting thing. Of course, nigrostriatal, right? That's one of the that's the never say of the 4 dopamine pathways. So that's movement. Okay, that's movement pathway. One of the 4 dopamine pathways, nigrostriatal, never say. Now, that makes sense, right? That's part of the movement, and therefore that's what would make them tick and have motor tics. So obviously that's the case. There's some with group A beta hemolytic streptococcus. Really interesting, huh? They have strep throat, and they get a pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. What a long term. PANDAS. It should be PANDAS E, but they leave the infection off. So really interesting. People get strep throat, and then they'll get all these movement disorders. I find that kind of fascinating. What is the mechanism of action between getting strep throat and tics? We don't know. Probably some kind of autoimmune disorder going up to the brain. And here's some differential diagnoses for ADHD, for Tourette's. Clonidine, guanfacine, or these low alpha adrenergic drugs. There's some more. You can read those. Autism spectrum. You can see the box there. Asperger's no longer is part of the DSM, mainly because there was not very good inter-rater reliability with Asperger's. Some people would diagnose it and others wouldn't, so they just got rid of it, and it's now all spectrum, man. Again, here's the symptoms. You can read that, fair enough. Repetitive stereotype behavior, etc. It is increasing in prevalence over the past 2 decades. We don't know why. Might be increase in recognition of it. I doubt that. I think it's increased in a number of cases. I really just do think that's the case. For whatever reason, it is increasing. We don't know why. Boys have it more than girls. About 4 to 1. Excuse me. Here's some things I just throw out there. TV, probably not. We can see the fusiform facial recognition area. That with autism, it's less. Of course it is. That's part of the problem. They don't recognize faces well. Cerebellar activity, amygdala activity, we see all these changes in the brains. Polymicrogyra, so they have a bunch of small gyri. Remember, the gyri is the brain tissue, and the sulci is the space in between. Maybe it's failure of normal pruning, loss of activity brain-wise, small limbic structures, densely packed rather. Yeah, I don't know. This is what we see. It's not cold. It's not cold parents. Some data came out on cell phones. Actually, I know a few people who really believe all the microwave radiation from cell phones causes autism and all kinds of trouble. It's an interesting thing. It'd be hard to investigate, but it'd be kind of interesting to investigate. And definitely not vaccinations. Anti-vaxxers are putting people at risk. So what do? Behavioral and communication. Those are the 2 main things. Behavioral modification, augmented communication system, point to pictures and symbols, that kind of idea. These really can help make them more flexible with rules. You really want to treat them young too. That's another kind of key component, is you want to have people with autism get into care at a very young stage, even 3 years old. If doing that, there's a lot more neuroplasticity, of course, and by having the neuroplasticity, you're able to make an intervention earlier on and have that be more effective. So early intervention really is key for people with autism. But there's more things. Parental training, communication, sensory stimulation, animal therapy, especially horses, which is kind of interesting. They can often relate better with horses than they can humans. Oxytocin, the cuddle drug, there's some studies with that. Symptom-targeted medication. If there's agitation, you can try to treat that. Remember to target symptoms, but there's not a anti-autism medication. It's also pretty interesting. There's people are aging out, it's called, where they're going from the child and adolescent system to the adult system. This is like a major problem because the adult system isn't really capable of handling them. They kind of fall between the gaps. Are they intellectually disabled? Well, not all of them. Some of them are not. Some are. Some have impaired verbal skills. Some do not have so much impaired verbal skills. So, do they go into the intellectual disability system or the adult mental health system? They kind of fall through the cracks. There's not really anything set up for adults. It's a major problem. One that hopefully we'll be able to figure that out. I might save this lecture because I want to go over some of this with you. IQ is not as important now. It's more function. This is an IQ bell curve. Used to be that mental retardation, which is the old term, was 70 and below. It's not anymore. It's now a matter of function. You can look that up. Academic domain, social domain, and practical domain. Go ahead and look that up in 96. Lots of causes. Prenatal, etc. Downs is common, Fragile X is common. Many types of things cause intellectual disability. Anoxia is lack of blood to the brain at birth, so that's prenatal. And do you treat them? Actually, there's a whole other lecture on that. I'm going to kind of skip over. Actually, I think this is involved with it now. I think I combined them, didn't I? Yeah, I did. So I'll continue. So various school and community programs for it. State schools, normalization, special education, mainstreaming. These can help treat other psychiatric disorders. Housing, where they're going to go. Treatment of medical problems. Constipation is a big one. Impulse control, school. So there's a lot of things you can do. But again, a big problem is these people are turning 18 and then they go into this completely different system. That can be quite the challenge. Yeah, I think I do have more. So I'll have whole nother talk, and I'll use that on next Tuesday because sometimes I want to give a little bit more in person than online. So enuresis, it's wetting the bed. Boys more than girls. Encoparesis is pooping a little bit in your pants. Incontinent stool. Boys again more than girls. Boys kind of forget to go, and pretty quick you're bound up, and you have to use mineral oil, enemas, decompressing the bowel, get it working again. Behavioral endocrinology. There's a part of our endocrine system that wakes us up when we have to pee in the middle of the night. That process has not been developed with boys with enuresis. It can be embarrassing, right? People can't go to sleepovers because they have this enuresis, that sort of thing. Decreased fluids at night would be a treatment, so they don't have as much fluid to make pee out of. And DDAVP, that's the antidiuretic hormone that can be used. Diuretic means you pee, right? Diuresis means you're peeing a lot. Antidiuretic means you're stopping yourself from peeing. Child abuse. All kinds of different child abuse, physical, psychological, sexual, and just neglect. Really kind of a big problem. We're going to I think we're having a person come in and talk about sex offenders, which is really a horrible thing. And we'll have from the basic idea from here that I want to share is that there's mood, anxiety disorders, post-traumatic stress disorders, substance use disorders. All those things can stem from early childhood abuse. There's an idea now of intergenerational abuse, where grandparents will abuse the parents who abuse the children, who abuse the grandchildren, and it just goes from generation to generation to generation, and as a sort of an unfortunate cycle. And last, neurobehavioral disorder associated with prenatal alcohol exposure. More than minimal exposure. What's minimal exposure? That's one of those qualifying terms. It's like, well, what's more than minimal exposure? Like any, right? I mean, why would you risk any exposure? Excuse me. Should we have women going to jail while they're drinking? Probably not, but it's a hell of a thing. And there's other drugs. Methamphetamine being a big one now. Opiates is a big one now. Marijuana, people think they can get high while pregnant and it doesn't affect the kid. Of course it does. Don't be stupid, people. So, lots of other drugs can people expose their children to in utero. And that means in uterus, in uterus. So it's pretty tragic, if you ask me.